types of glaucoma, and risk factors, diagnosis and management. Feel free to type your questions in the chat and I will respond during the course of this evening's webinar. Just remember, there is no such thing as a stupid question. What is diabetes? Diabetes is a metabolic disease characterized by hyperglycemia, which results from defects in insulin secretion, insulin action, or both secretion and action. So just leave that up for a couple of seconds in case I was speaking too quickly.
Oh, Candice, I would let you know we have patients coming from Canada.
Welcome, Canada.
Canada. We have Canada in the house.
Excellent. Welcome, Canada.
We also have Aruka.
Beautiful. Welcome, Aruka. So diabetes could be categorized or placed into two categories. I'm sure you all are aware of those two categories. There's insulin-dependent diabetes and non-insulin dependent diabetes. The table illustrated in front of you actually does a quick comparison of the two types of diabetes. So type 1 diabetes, it's an acute onset pretty quickly. And type 2 diabetes, it's sort of a gradual onset. Type 1 diabetes, like the name suggests, insulin dependent, it's actually managed by use of insulin, whilst type 2 diabetes is diet or tablet controlled. Type 1 diabetes could typically be found in the young, whilst type 2 usually occurs at the age of 50 years and over. Usually, non-obese persons could have type 1 diabetes, whilst obese persons would have type 2 diabetes. Now, this is not a hard and fast rules, right? Because, some obese persons may actually have type 1, at least in the youth. Type 1 diabetes has 50% concordance with identical twins, whilst type 2 diabetes has 100% concordance with identical twins. In type 1 diabetes, there's a 10% family history, whilst there's a 30% family history in type 2 diabetes. So in this slide, we're going to discuss the epidemiology and global burdens of diabetes, right? Basically, we're going to discuss what the World Health Organization has to say about diabetes. The World Health Organization estimates that 830 million persons worldwide had diabetes. 537 million are adults, and this figure is estimated to increase to 629 million by the year 2045. Type 2 diabetes accounts for 90% to 95% of diabetes within the highest proportions in low and middle income countries. High blood glucose level is known to cause 4 million deaths each year, and the prevalence in adults has risen from 4.7% in 1980 to 8.5% in 2014. In Trinidad, there are more than 151,000 persons living with diabetes, a third of which are children. Who should test? Anyone who's age 45 years old and older should test yearly. You test at a young age or more frequently if you are obese, meaning your BMI is over 27, if you have a first-degree relative with diabetes, or if you belong to one of those high-risk ethnic groups. And just to bring it home a little bit, I do have a first-degree relative with diabetes, so on the odd occasion, I actually do test. I actually invested in an at-home kit. Persons who should also test would be women who would have given birth to babies over 9 pounds or who would have had gestational diabetes. And let's not forget those who are hypertensive. The criteria for diagnosis. So someone is diabetic if their elevated plasma glucose level is 200 milligrams per deciliter or 11.1 millimoles per liter or above. And they may also have symptoms of polyuria, meaning increased passage of urine, excessive thirst, polydipsia, and weight loss. If someone possesses a fasting plasma glucose level of more than 7 millimoles per liter or greater or 126 milligrams per deciliter or more, they could be diagnosed as having diabetes. Another test that could be done is called the oral glucose tolerance test. I'm not sure if any of you would have heard of it. Anyone have heard about the oral glucose tolerance test before? Or anyone has had to do one?
No.
So what an oral glucose tolerance test is, it's a test where basically you test to see how quickly your body metabolizes the glucose or breaks down the glucose. So a fasting blood sugar level test is done initially. You're given some glucose to drink, an extremely sweet drink, and then your blood sugar level is tested again at the 30-minute mark from consumption, the 1 hour mark from consumption, and then the 2 hour mark. If after 2 hours, your blood glucose is more than 11.1 millimoles per liter, then you would be considered diabetic. So this chart actually gives you a brief breakdown as into the meaning of the glucose level, blood glucose levels, and the figures to look at, right? And we will discuss a little bit about the figures later down. Generally, someone who has a normal blood glucose level, again, under 125, under 7, right? Hypoglycemia is just as dangerous as hyperglycemia. So you would find that somebody who is hypoglycemic, their blood sugar level is too low, and then obviously that's like if it's under 3.9. Also, if somebody is hyperglycemic and their blood sugar level is greater than 10, well then, of course, you need to take action, right? So the diagram speaks for itself. Everybody's okay? Just a gentle reminder, if you have any questions, feel free to type it in the chat for me, all right? Any questions coming in there, Susanna?
Not as yet.
The shy bunch. Okay. So welcome to our first I Spy session. And in this session, what we are going to do is we're going to chat about the ocular complications associated with diabetes. Firstly, we will begin by speaking about disorders of the eyelids. So in this lovely photo I have here, the person on the right is illustrating a disorder we call blepharitis, which is a disorder of the eyelids. What you find is, in this case, you get crusting of the eyelids itself. Sometimes the lid margins thicken and become red. There's a little bit of redness of the eyes. You could see the blood vessels here. And you could experience a bit of dryness, blurred vision, and so forth. So to treat this, we recommend use of some lid wipes, and they help get rid of the crusting. And we also recommend use of eye drops to just soothe the eyes, reduce the irritation and the burning sensation, all right? Diagram to your right shows you something called a chalazion. And a chalazion is also an inflammation of the lid margin. It usually occurs when the meibomian glands become blocked. And in these cases, it's recurrent in cases of diabetics. So what we tend to recommend is, in this case, we recommend warm compresses. If somebody has a recurrent chalazion, what we would recommend is that they see a specialist ophthalmologist where they will be given an antibiotic. And sometimes if it's taking too long to go down, it has to be surgically removed or excised. All right? Interesting stuff, huh? Let's go on to the conjunctiva. Another ocular complication that could occur is called a subconjunctival hemorrhage. Basically, this is where a blood vessel bursts in your eyes. Most people don't know this is happening to them. They're usually told by someone, why does your eye look red, right? It could also occur in persons who has this change of pressure. So let's say you stand up too quickly or you lift something heavy, could also happen. In diabetics, though, it's recurrent. So again, we would recommend some eye drops to soothe any irritation. It tends to resolve within about, let's say, 7 to 10 days. If it takes a bit longer, that's when we recommend you see a specialist ophthalmologist. And let's go on to extraocular muscle palsies. So
Candice,
yes,
sorry. So we have a question.
yes.
When you have high pressure behind your eyes, is that a sign that you are developing glaucoma?
Yes, in some cases, but some people do have ocular hypertension. So yes, in some cases, it could be that you're developing glaucoma. It could be that you're also a high risk. So you could have high pressures, but don't have glaucoma just yet. So it just means you belong to that high risk group. All right.
Great. And I also have another question too. And again, guys, feel free to unmute and ask any questions. But more importantly, the conjunctiva, yes.
Yeah.
That version of redness for, like, in particular, like persons who are gardening, who are outdoors and they don't wear safety goggles. Is that something that you see very common in that type of profession?
So ever so often, yes, you have someone who might be cutting the lawn or pruning the trees just before Christmas and they come in with, something poke them in their eyes. So that's something slightly different because in the subconjunctival hemorrhage, it's something just happens sporadically. Whereas if you have a poke in your eye and you get this redness, yes, it could resolve, but if there's eye pain, we do recommend you see a specialist ophthalmologist just to be safe.
Okay, I have one more question in the chat. Can the fasting tests have high glucose results other than diabetes?
That's a good one.
Well,
You could have a scenario where it's a one-off. You may have eaten late the night before, but it generally if you show up with a fasting test that's high, we recommend you see your doctor. And like I said, it could be one-off. Your doctor would try to manage you, probably diet control and monitor you closely before you diagnose right away or before you're placed on medication.
I hope that helps, Nadine. Let us know in the chat via emoji. Go ahead, Candice.
Thank you for all the questions. Keep them coming. So we're going to have a little chat about extraocular muscle palsies. So our extraocular muscles are the muscles that help us keep our eyes straight and also help with the eye movement, let's say from left to right and so forth, right? So in diabetics, however, we have a type of palsy that could occur, which is actually a third nerve palsy. And what actually happens, we have, if you would look at the diagram, this patient's right eye, the lid is actually sagging. It's called ptosis, and that has to do with the muscle palsy. And ptosis could happen for other reasons as well. So obviously, if it occurs and you've never had it before, you would see a specialist and they would do the necessary assessment, right? But we're just letting you know that this could happen in diabetics, especially in persons at an older age. What also happens is that the eye itself turns down and out, and that's also an indicator of a third nerve palsy. Right, so now let's go on to disorders of the cornea. So this is important and it's often forgotten, especially by diabetic contact lens wearers, you cannot forget your cornea. And your cornea is important because you could actually have a bit of what we call epithelial erosion in diabetics, and this could be recurrent. So if symptoms might be a little bit of pain, a little bit of glare, or just a slight irritation. So what we would do when you come into us, we would do what we call a staining check, where we put a little bit of yellow dye into your eyes and we assess the cornea. All right. Diabetics could also be prone to transient punctate keratitis and what we call stromal edema. The cornea is actually supposed to be clear, but sometimes it goes hazy when, there's not enough oxygen. Also bearing in mind, and we know this happens with diabetics, they lose a little bit of their nerves, so they lose a little feeling. This could also happen in your cornea. So you have reduced corneal sensitivity. You also have reduced resistance to infection and reduced healing rate. You ever see a diabetic, they might get a cut on their arm and it just takes longer than normal to heal. The similar thing happens in your cornea, okay? So you pay attention to these bits. Let's go on to the crystalline lens. So I am sure everyone here would have met or came across someone who would have had a cataract. So what cataracts are? They are actually haziness of the lens, and it could cause your vision to go blurry. You may experience increased glare, or in some cases, double vision. So there are two types of cataracts which tend to be associated with diabetes. And the first one we're going to discuss this afternoon is called a reversible snowflake cataract. So this is a cataract which can happen due to poor metabolic control, but it's reversible. It could resolve spontaneously, but you must control your blood sugar levels, right? The second type of cataract is called a cortical cataract. And non-diabetics could get this as well. It usually occurs over the age of 65. However, it can occur earlier in diabetics, like in their early 40s. So cortical cataracts, they literally look like bicycle spokes, those spokes in the bicycle wheels. So this is what will cause the cortical cataract, and it tends to be associated with extreme glare when driving at night. Let's go on to diabetic retinopathy. It's the most common cause of blindness in the working population, right? And it's where the blood vessels, the small vessels in the back of the eyes become compromised. So you have the small vessels that are affected would be the arteries, the capillaries, and venules. It is characterized by vascular permeability, ocular hemorrhage, exudates, and new blood vessels. And our next diagram will show us. So when I say I'm going to have a good look at the back of your eyes, this is what we'll look at. This is your retina. So the rightmost diagram is actually showing you an illustration of a normal retina. This area is what we call your central vision, is the macula. Then you have these blood vessels, and to your right, you have the optic disc. I want you to pay attention to this. We'll have to discuss this a little later. All right. So in someone with non-proliferative diabetic retinopathy or pre-proliferative diabetic retinopathy, you find hemorrhages. So there are little leaking of the blood vessels, little bits of blood found on your retina. Sometimes it resolves on its own, sometimes it doesn't. So once we see pre-proliferative diabetic retinopathy, it's our duty of care to refer you to the specialist ophthalmologist. You also have hard exudates and aneurysms. In the advanced stage, what you have here is proliferative diabetic retinopathy, where you have the hemorrhages, the aneurysms, and the hard exudates, but you also could have some new or abnormal blood vessels occurring at the optic disc. New blood vessels could also occur near the central vision and also in the iris at the front of the eye. Obviously, you wouldn't be able to see it with the naked eyes, only when we have all the look at our slit lamp, that's when you would observe it. Is everyone okay?
We have a question from
Yes.
Jennifer Candice. Are cataracts
Yes.
only associated with diabetics? I am not
No, it's not.
diabetic
Oh,
and
sorry. Go ahead.
have had 2 cataract surgeries.
No, it's not actually. Um, in some cases, it has to do with if you would have had some sort of traumatic injury to your eye. Some people are born with cataracts. There are congenital cataracts. Another case could be depending on if you're on steroids for prolonged periods, you could have cataracts. Also, certain people who would have different types of treatment, i.e., radiation therapy, which could have affected or their eyes may have been exposed, they could develop cataracts sooner than others. All right.
I have a
So,
question to
mhm.
Candice to dovetail that. So
So
Jennifer has disclosed that the surgeries have taken place in both eyes. So
correct.
So
Okay.
my question would be, is there a reality that cataracts could come back? Could they reoccur? And if so, and
So,
what age?
okay. So cataracts can't reoccur because what they do is they remove the cataract and they insert what we call an intraocular lens into the lens capsule itself, right? So it can't reoccur. But what you would find happening though is when they remove the cataract, it's almost like a suction, and sometimes bits of the debris gets left at the back of their eye. Right. So with some time, it kind of rises up and it clings to the lens. So that's not a cataract. We call that a posterior subcapsular opacification. When that occurs, that's when you need to do laser to remove it. So you might have a cataract in 2020 and you have perfect vision. And then by 2027, you suddenly realize, wait, my vision isn't as good as it used to be. It's not that the cataracts came back. It's just that you got some opacification there and it's now hampering your vision.
And would you say, just for the purpose of the persons on the call, where would you see the age tends to be persons being diagnosed to have surgery, specifically to cataracts?
So generally speaking, you would think 60 years and above. However, within recent times, I've had a couple of patients who I would have had to refer to the specialist ophthalmologist in their 50s, and sometimes again in your late 40s. So it's a case by case basis.
Okay, thank you.
You're welcome. Excellent. So let's have a little chat about fluctuations in prescriptions. So don't know how many diabetics are on this call, but you ever went to your optometrist thinking you just want glasses, but your blood sugar level is elevated and they said, no, you cannot get glasses today. So this is because when your blood sugar level is not well controlled, it could change the hydration of your lenses and thus alter your prescription. So if you were to get prescribed glasses on a day when your blood sugar level is high, and then a month later you go back to your doctor and your blood sugar level is well controlled, you will actually experience a shift in your vision. And then you come back to the optometrist and say they gave you the wrong glasses. So fluctuation in prescription is something that's quite common in diabetic patients. So generally, there is more of a short-sighted shift, meaning you could go from having 0 prescription to a -1 or -2, or you could go from a plus prescription to 0 or plus to a minus, right? So, like I say, in the event your blood sugar level is elevated on the day of testing, we ask you to get it under control, one, or it might be a one-off thing that day that it's elevated, right? So we give it some time before we prescribe. In some cases, though, you would get a more long-sighted shift, or what we call a hyperopic shift, and that occurs after a diabetic patient would have undergone a period of strict metabolic control. It means they're on their meds, they're eating healthy, they're eating right. And now you go from being short-sighted to far-sighted. All right? Is that okay? This diagram actually shows you what your blood glucose level should be like. Fasting meaning, and fasting doesn't mean you starve yourself the night before, but fasting actually refers to first thing in the morning before breakfast. And then you have what it is like for a normal person, somebody whose blood sugar level is impaired, and somebody who's diabetic. The chart also illustrates the blood sugar level readings directly after eating. And then you have the blood sugar levels 2 to 3 hours after eating. All right. So generally, when you come for an eye test, what I tend to advise is that your blood sugar level should be under 140. And we do that because we give diabetics a little bit of leeway, right? It's not always when we say a diabetic blood sugar level is well controlled, it may not necessarily be under 125. So we give you a little leeway. So it should actually be under 140 to proceed with spectacles. All right.
And Candice, this is where I also want to interject, having had experience from others. So would you recommend specifically for patients who are diabetic, like you said, if they come and their ratings are a little bit off, as much as sometimes they may not be turned away, do you think that it's recommended for them to get like a spare, a spare, because of their levels being not consistent, for want of a better word?
No, I don't really agree with getting a spare pair. Then they might have about 10 different spares. I think it's going to be a lot of money for them to invest in. If they have the money, fine. But I certainly tend to recommend let's try to control. Sometimes they're on meds and it's still high. I recommend, all right, let's see a doctor. But I will not turn them away. What I tend to do is I still try to do the eye test, but I wouldn't necessarily prescribe glasses because some of these patients may not have had a check at the back of a health check in a while. So what we would want to do is check the health of their eyes and make sure there is no diabetic retinopathy. All right.
And I
So
guess the the
mhm.
the takeaway here too is also for the patients to, be honest and speak of what medications you're on, because that would be giving more insight as to what's really happening with certain medications that you may be on.
Correct. I believe in honesty. It helps us, but it also helps the patient in the long run. This hasn't happened in a while, but yes, you may have had a one-off case where a patient said, "Well, I could have just told you that it's well controlled, but it's in fact it isn't." But then, we want the best interest for the patient, right? So we encourage you to be truthful and just be honest. We're all human, we all make mistakes. We all indulge in an extra scoop of ice cream on a Sunday afternoon or a slice of cake. I heard we have some bakers in here in the group. So I'm sure that baker who baked a cake 2 days ago, she probably had an extra slice of cake recently. And she might have shared it with someone who is diabetic, and that person may have, their blood sugar level may have gone up a little bit. But it's all about everything in moderation. Everybody's good? Hello?
Yes, we're good.
Yes, we're
Okay.
good.
Yeah, good. So we are going to proceed, right?
I would
We
say
are going.
this topic, I want to just interject because I want to be able to hear from the 23 persons that have joined this call. If you are able to put in the chat or just unmute, have you all ever heard the term glaucoma before Candice moves on?
Yes, I've heard it before. Good afternoon, everybody.
Good evening.
Yes, I've heard it as well.
Yes, I've heard it as well. My uncle is suffering from it. He had to do eye surgery. So it's in my family actually. So I'm learning a lot from this meeting this evening.
Excellent. Over to you, Candice.
Good. So, glaucoma is considered the invisible vision threat. As I introduce this topic, I'd like to just discuss the link between diabetes and glaucoma. Diabetes and glaucoma are linked primarily through the increased risk of developing glaucoma for individuals with diabetes. And here are some key connection points. The increased risk, people with diabetes are twice as likely to develop glaucoma than in comparison to somebody who's not diabetic. The risk increases with the duration of diabetes. But that being said, you may have someone who is not diabetic who could also develop glaucoma. There are also vascular effects to consider, and I'm going to bring that up now. So when we speak about the vascular effects, this is a damage. This damage could affect the optic nerve. And we would have pointed out in the diabetic retinopathy photo, there are some blood vessels growing at the optic nerve in the diabetic patients. And this could affect your optic nerve, okay? And then again, like we said, it brings me to my next point, diabetic retinopathy. Diabetes can lead to diabetic retinopathy, where damaged vessels in the retina can cause increased eye pressures and subsequent optic nerve damage, leading to glaucoma. And then studies have shown that there is the issue of oxidative stress, where both diabetes and glaucoma are associated with oxidative stress, which can contribute to the progression of these conditions. So let's chat a bit about the definition of glaucoma. Glaucoma is a group of eye conditions that damage the optic nerve, which is critical for vision. This damage may be caused by abnormally high pressures in the eye, and all forms of the disease is associated with visual field loss or peripheral vision loss as the damage progresses. And when we speak about visual field loss, we refer to how well, when you're looking straight ahead, you could detect something coming off to the side. You know, that's important when you're driving, right? So glaucoma is one of the leading causes of blindness for persons over the age of 60, but can occur at any age. And I would like to point this out. I have had patients who have been diagnosed with glaucoma at the age of 18, some in their 20s, some in their 30s, right? So it's one of the most aggressive form of irreversible blindness, and I feel as though we need to be more aware of it. So now I would like to share some statistical data with you. So over 78 million people worldwide have glaucoma. 111.8 million are predicted to have glaucoma by 2040. 90% of glaucoma is undetected in developing countries. 1 billion have no access to eye care due to unfair distribution. Every 1 in 200 people aged 40 could potentially have glaucoma. And this figure increases when you hit the age of 80, where 1 in 8 persons could now have glaucoma. Family members of those with glaucoma have a 10-fold risk of getting glaucoma themselves. Now we're on to the Did You Know segment. Did you know that most people with glaucoma are not aware of it? Most glaucoma patients have 0 symptoms. Causes of glaucoma. Yes.
Before we go into the causes, I just don't want to lose this question or stream of thought, but question here, what causes the vascular effects outside of diabetes?
In some cases, you have a patient might be hypertensive, right? They may have some bleeding at the back of their eyes. Other vascular effects, it could also be probably even sometimes medication. But when it's not always associated with vascular effects, actually. Remember, at the optic nerve, there are other types of pathology that could potentially present. Glaucoma is just one of them. Yeah.
And
So
sorry, go ahead.
Proceed, go ahead.
Okay, so I
Yeah.
think, I know we're getting into the meat of it, but I wanted to just jump in some of, again, similarity. When a patient is receiving this type of information, it could be a bit overwhelming.
Yes.
So in terms of that level of support from family members, and so, what would be how could you navigate with them in terms of the next steps when they first get diagnosed? Where could they go?
Right. So actually, and it's funny that you brought up the whole issue of diagnosing. I would look at an optic nerve and I might think, okay, this definitely looks glaucomatous, but actually the ophthalmologist would have the final say. So in cases where I'm like, no, this looks really suspicious, I would have a discussion with them, describe what I see, and we'll get to that in the next couple of slides. And then I would express, like, listen, this is why I need you to see the specialist ophthalmologist. He is the one who has the final say. It looks suspicious to me because you can't just say, yes, you have glaucoma. What I would say, it looks suspicious of. And I also wouldn't say, well, I see a thing at the back of your eye. I have to, I have to break the news with a little bit of tact, but I have to remember that the ophthalmologist has the final say. So I would say, I am sending you to the specialist ophthalmologist. He is going to do some further testing. All right. So I know some patients, it's like a culture shock, and some patients are in denial, but it's just how you present the information to them.
And of course, taking it home again, that the ophthalmologist has the final confirmed version to better support the confirmed condition of the eye.
Correct. Yes. So we would do a visual field test, and some practices have an OCT machine, and we'll get to that later on as well. However, the ophthalmologist, even if an optometrist does the visual field and OCT, in some cases, we actually have to send the results with the patient to see the ophthalmologist.
Thank you.
Welcome. So the causes of glaucoma, the exact cause of glaucoma is not always clear. However, it's generally related to higher than normal pressure inside the eye. And we call this the intraocular pressure. This pressure is due to a buildup of aqueous humor fluid that flows in and out of the eye. So when this fluid does not drain out properly, it accumulates and increases the pressure, thus damaging the optic nerve. Key areas assessed in patients. So there are 3 key areas we tend to assess. And in the first one we're going to chat about is what we call the intraocular pressure. So I'm sure someone in this group would have heard someone say, I have high eye pressure. So when we say high eye pressure, we don't mean high blood pressure, but it's the intraocular pressure. And this diagram depicts different methods of measuring. This picture here actually is what we consider the gold standard. Most practices has the non-contact tonometry, which is the puff air test that everybody dislikes, right? But it's one of the compulsory tests when doing an eye test, okay? Secondly, I'd like to chat with you about another thing we look at, which is the anterior chamber angle. So at our slit lamp, what we do is shine a light at the corner, and this is the beam of the light. This gives us actually a cross section of the cornea, and this optical space here, this dark optical space is what we compare it to. So we look at the ratio of the size of this space to the cross-section of the cornea, and we grade that. The technique, there are different techniques, but the technique mostly used is actually the Van Herrick technique. So if this area here is really, really thin and you can't see any dark area at all, that means it's zero. That means we need to refer this patient right away. All right, this patient has a nice open anterior chamber angle, we call it, okay? And similarly in diagram B, again, a nice open anterior chamber angle. Thirdly, we then go on to look at your optic nerve. So we would say something again like, let's have a little look at the back of your eyes. So this is a close-up of the optic nerve. It almost looks like a CD. So this circumference here, we call this area the disc, and this inner piece, we call that the cup. So what we do is we look at the comparison of the size of the cup to the size of the disc. So if you were to look at this, this is approximately 0.3, which is a normal optic disc or optic nerve. You'd hear me using the term interchangeably, okay? But optic nerve, optic disc, basically, it's the same thing. All
Candice,
right?
we have a hand up. Maria, if you
Yes.
could tell us, is it that you're not
Hi,
seeing the
hi, good
diagram?
afternoon. Yeah, I'm not seeing the diagram because I'm trying to follow with what you're saying. Good afternoon, everybody. I came on late, so I
Good
am trying
afternoon,
to,
Maria.
good afternoon. I'm trying to grasp with everything that you're saying, but I'm not seeing I'm not seeing the diagram. And also, I don't mean to ask a rhetorical question, but what about children? I'm a teacher. And a lot of the children under 5 years old are wearing glasses. So that crossed my mind. And also, too, a lot of them are on screen time. I don't know if you spoke about that. I know there's no direct, with respect to glaucoma, nobody knows the exact cause, but I am
Correct.
concerned about this screen time.
And you should be, Maria, to be very honest. Pre-COVID,
Uh-huh.
we say to children, I believe it was under the age of 11, I would say to parents actually, limit the screen time. So allow 1 hour per day. Remember, COVID came, we had nothing to do. Everything was online. Church was online, school was online. All your social interactions were online. So since then, some people have not really gone back to that discipline pre-COVID. So
Uh-huh.
they've now increased the screen time. And with increased screen time, sometimes, yes, it could have an impact on your vision, not glaucoma, but it could cause, we've seen an increase in the level of short-sightedness or myopia. So when we see this, we ask parents to reduce the screen time. Do a little bit of outdoor activity, go outside and play, probably do some stuff around the house, wash wares and stuff. I mean, I don't know how much a 4-year-old could do, but definitely we advise to reduce the screen time. So yes, it's actually a growing trend where we're seeing more and more children presenting with needing spectacles. And I encourage parents to reduce screen time, less than an hour per day. Does that answer your question? You have any other questions or
Yeah,
comments?
yes, I do have another comment because I came in when you were talking about diabetes because I found
Right.
too, I interact with a lot of little children. I'm a primary
Mhm.
school teacher, and I'm
Mhm.
very adamant about what they eat because I have noticed that they eat too much sugar, and my concern too with diabetes because I'm noticing these little children are obese. So I am wondering too. I mean, I am there trying to encourage parents to see that healthy eating is important, not only from the diabetic point of view, but also for even for brain function. And now that you're talking, well, the diabetic concern is a real concern coupled with the screen time.
Healthy eating, it takes a bit of planning, but I believe when you get into the groove of it, you could really be organized and so forth. Some people unfortunately don't have the time or the resources, so they actually resort to a quick fix, which would be a snack. I tend to advise a lot of green leafy vegetables, spinach, kale, a lot of fruits, right? But remember, some fruits are also high in sugar. So it's everything in moderation. Maria, I mean, the most we could do is educate parents.
Yeah, yeah,
You
yeah,
know? So I don't know if your school has the facility to have like health fairs and stuff, or you just kind of try to make it fun.
yeah, yeah. We did have a health fair, but I didn't think of this topic. I really didn't think of this topic.
Okay.
Yeah,
So you could chat with, I mean, when you have parents meeting and so forth, encourage them. So some parents would say children don't like veggies, but you know what? You could mince or chop up some spinach and put it when you're making a shepherd's pie. You mix it in with the potato. That's a way for them to get the veggies. You
right.
know, you
Yeah.
grate the carrots and at this stage you should be eating a lot of carrots. So you grate the carrots and you put it in the pilau. By the time you finish cooking the pilau, the children wouldn't even, recognize that there's carrots there. They're just eating. So, you have
Uh,
to find innovative ways.
and on the topic of because I came in when you were talking about aging, right? And carrots, right? So is it that because I'm past 50, um, because I am concerned too about my eyes, my health. I have bulk up more on my carrots. Is it too late for me?
Well, actually, you could have the carrots, but I would also suggest eating a lot of green leafy vegetables, spinach and kale.
Yeah.
The nice sweet peppers are good, the bright colored ones, the red, yellow, orange sweet peppers. I know these things are costly, but it does help. So just a general healthy lifestyle and everything in moderation. No one's saying you can't have a little glass of ice cream on a Sunday.
Yeah. And I got the diagram, so now I can follow you.
Okay.
Thank you so
Okay.
much.
Okay. So you're welcome, Maria. So I am going to speed it up a bit, right? So let's just have a chat. We're going on to a normal optic disc versus a glaucomatous optic disc. So a normal optic disc, like I would have said, this is the cup and this is your disc. So in this disc, it's about the cup size. The cup to disc ratio is 0.3. However, in this glaucomatous optic disc, the cup to disc ratio is roughly about 0.8. So this is definitely full-on glaucoma. If somebody came to me for the first time and I'm seeing this picture on your right, I'll be referring them to the specialist ophthalmologist right away. Right, so after we do those three tests, the other bits that we tend to look at or tend to do would be a visual field test. I would have mentioned that briefly, where we spoke about the peripheral vision test. So if we feel as though somebody is a glaucoma suspect, we recommend a visual field test, right? And again, how well, when you're looking straight ahead, you could detect something off to the side. I tend to highly recommend having a good night's rest the night before doing this test because it's quite easy to fail. We're on to optical coherence tomography. So this is one of the more recent technology. And this also gives you a 3D vision of the optic disc. And these diagrams here assist with detecting glaucoma. Now, some doctors would recommend, we call it an OCT, the OCT first, and then the visual field test. Some would just use the OCT alone, and some would go with the visual field and then the OCT, right? Each patient is unique. So most ophthalmologists would have to tailor their tests based on the case-by-case basis. So don't go telling your ophthalmologist how to do the test and in which order and asking him why he didn't do this test, right? Let's go on to the risk factors. Sorry, I may speed up a little bit, but I'm sure Susanna is going to make these slides available to you on her website, okay?
I would also interject there too, Candice, to let the listening and viewing subscribers that, guys, I know we at 7:24, but once you're okay, we want to get to all the information being shared. So if it's okay, I hope you can stay on because I know it's from 6:30 to 7:30. So if it's okay, just put it in the chat. Candice, keep going.
Keep going.
So I can keep going. Everybody's fine?
We have a nod. We have thumbs up.
Beautiful. Beautiful. Okay.
Not a
So,
problem.
excellent. So risk factors associated with glaucoma, again, these are the general risk factors, all right? You have age. People over the age of 60 are at higher risk. Ethnicity, meaning I have African Americans, but we mean Africans, Afro-Caribbeans, Asians, Hispanics are also at higher risk. Once you have that family history, it also increases the risk. Medical conditions like diabetes, high blood pressure. But I'd like to point out that someone could have high blood pressure and not have glaucoma, okay? So don't think, oh my God, my blood pressure is high, I have glaucoma. It doesn't always work like that. Everybody is unique. Patricia Seeley, I'm seeing you. Welcome. And certain medications, for example, persons who are on steroids are at increased risk. And then there is the conversation about the eye anatomy, where certain structural characteristics of the eye can predispose individuals to glaucoma. I'm seeing bits of, is that writing on the screen?
Yeah, there's bits of some of your markers. That's okay.
Oh, that's my marker. Oh, sorry. How did that happen? Okay, learning something new. All right, so primary open angle glaucoma. And we're going to look at, this is the first type we're going to look at this afternoon. It's where the intraocular pressure, or IOP, it's greater than 21 millimeters of mercury. So it uses the same unit as pressure. In this case, there's a glaucomatous optic nerve damage and an open anterior chamber angle. Characteristics of the visual field loss. Characteristics of visual field loss as damage progresses. Absence of signs of secondary or non-glaucomatous cause of optic neuropathy. Remember, other pathology could cause damage to the optic nerve as well, okay? So this is the most common type of glaucoma in individuals of European and African ethnicity. It also affects both sexes equally. How do I get this marker off? Sorry about that, guys. So risk factors associated with primary open angle glaucoma, and some of the risk factors would be IOP. So it means the higher the intraocular pressure, the greater the likelihood. Another risk factor is age. It's more common in older individuals. Race, it is significantly more common and develops at an earlier age and may be more difficult to control in Black individuals than white individuals. Once you have that family history of glaucoma, again, so you have that first-degree relative, it makes you more exposed to potentially developing glaucoma. And then diabetes, remember, many studies would have suggested the correlation between diabetes and glaucoma. So being diabetic increases that risk. Persons who are short-sighted or more myopic, right? This is associated with an increased incidence of primary open-angle glaucoma. And myopic eyes may be more susceptible to glaucomatous damage. Now, I wanted to add here, in persons who are myope, the optic nerve often looks suspicious, and there is a little bit of cupping. That means their cup is a little bit larger than normal. We call it physiological cupping. But in the odd occasion when we see it, we may send to a specialist ophthalmologist, depending on the circumstance, to just have a routine check, or we would manage in store. Other risk factors would be if someone has vascular disease, hypertension, cardiovascular disease, and so forth. Another type of glaucoma is the angle closure glaucoma, right? It's also known as closed angle or narrow angle glaucoma. In this type is less common and occurs due to the occlusion of what we call the trabecular meshwork by the peripheral iris. The iris could block the drainage system and obstruct the aqueous outflow, resulting in a buildup of pressure in the eye. It requires medical attention, and it tends to be associated with a greater speed of progression and visual morbidity than primary open angle glaucoma. So this one is a little bit more aggressive, right? There are 3 classifications of angle closure glaucoma. First one we're going to look at is a primary angle closure suspect. And this is someone who has normal pressures, normal optic nerve, normal visual field, but the angle looks a little bit narrow. The second one we will look at is the primary angle closure, where the pressures are raised or there is excessive pigment in the trabecular meshwork, but the optic disc and visual field test results are both normal. Thirdly, we have primary angle closure glaucoma, in which there is optic neuropathy. This means that the optic disc is glaucomatous. All right? Risk factors of angle closure glaucoma. The pressures tend to be high. The higher the pressure, the greater the likelihood of glaucoma. It tends to present in persons 60 years and older. Tends to affect females more than males. Don't know why. And the race, persons of Far Eastern descent tend to be more at risk. And again, family history. Refraction, it says that typically somebody who is farsighted or hypermetropic is more at risk, but there is no clear-cut evidence to support this, okay? Types of glaucoma. We're going on to number 3, which is normal tension glaucoma. And the name actually says it all, right? Normal tension glaucoma means it's normal pressure glaucoma, and it's actually a variant of the primary open angle glaucoma, right? Some characteristics, the pressures may actually be less than 21 millimeters of mercury. So these pressures are within the normal range. Signs of the optic nerve damage may be present. So you may have a glaucomatous pattern, and this would take us to the angle tends to be open, and the visual field loss may occur as the damage progresses. Risk factors, again, patients tend to be older than those with primary open angle glaucoma. There's a high prevalence in females. We ladies are just lucky, huh? And race, it tends to occur more frequently in Japanese, meaning Chinese, the Asians. And again, the family history, there's a prevalence of primary open angle glaucoma, which is greater in families of patients with normal tension glaucoma than in the normal population. Another risk factor is central corneal thickness. And in some practices, some machines where you do the pressure readings actually give you the central corneal thickness. So someone who has a lower central corneal thickness or a lower thickness, they may potentially be more at risk than someone whose cornea is thicker. All right. And then we talk about systemic hypertension, which is a case where the nocturnal blood pressure drops and you have the obstructive sleep apnea syndrome. Secondary glaucoma. So when we speak about secondary glaucoma, this is a type of glaucoma that occurs due to an underlying condition that raises the eye pressure. So it might be injury, inflammation, advanced cases of cataract, diabetes, and again, side effects of certain medications, i.e. steroids. I
This
took the
what I see,
liberty,
Candice, could I ask just out
yes.
with the previous slide, is it worth knowing no, the other one with the list. Could stress be an added factor as well? Because it's so real. The other slide, I think, where you had the list. Your next slide.
Back or forward?
Forward.
Forward. All right.
Next one. Secondary. Yeah, this one.
Right. Yeah. Well, remember, we're going back to Kashaya's webinar. Remember we said that stress could cause the secretion of increased cortisol, and this could affect the blood sugar regulating system. So the fact that you become diabetic, it could increase your risk of having glaucoma. I don't think so. That would probably be more related to the primary open angle glaucoma and so forth. The secondary glaucoma tends to be where we know that something there is more like physical. So somebody who would have been placed on steroids for whatever reason, they may be more predisposed. Somebody who had a traumatic injury to their eye, that they had that injury and that caused the intraocular pressure to raise, and that's the reason why they develop glaucoma.
We have
So
another
it's a
question.
Mhm.
Sorry, we have another question. Does lack of sleep affect eye pressure?
That's a good question. Take me back to university days. Not not necessarily. It might increase by, let's say, 1 or 2 millimeters of mercury, but not necessarily. It's not one of those things like where I would say, okay, you didn't sleep last night, we have to repeat the pressure. I would only say that if you tell me you didn't sleep, but then we can't do the visual field test. But I wouldn't tell you can't. The pressure reading is high because you didn't sleep the night before.
Okay,
Is that all right?
that's
Yeah.
or the number of hours you sleep. So Jennifer, further to her question, is in asking the number of hours of sleep if that counts.
Well, the number of hours sleep could affect anything. So what do they say? You should get at least 6 to 8 hours sleep per night. So if you should at least allot some time per week where you get a good night's rest. So, like I said, there is no hard and fast rule. Yes, it could amplify it a bit, but probably like 1 millimeter of mercury. But it doesn't necessarily mean that you're going to develop glaucoma because you didn't sleep for you only got 4 hours sleep each night for the past 10 days or so. Yeah.
Sounds
So
good.
there's no direct correlation. Did I answer Jennifer's question?
Maybe I can expand it a little bit if you don't mind.
No problem.
Yeah, I have been diagnosed with glaucoma 24 years ago. And
Okay.
on my last visit to my ophthalmologist, the pressure in the eye was high,
Right.
higher than it normally is. So we are looking at it for another month to see if it changes, and then we will, do other things. So I was just wondering if the number of hours, so that's why I asked the question, because I would sleep maybe 6, 7 hours each night.
That's good.
So I was just wondering whether that had anything to do with the increased pressure in the eye, because this has only been I have 6 months visits in between. So, and this has only been with the last 2 visits. The pressure has been high. So we're just trying to figure out what is causing it. So that's why I asked the question.
Thanks for clarifying. Thanks for the clarification, Jennifer.
You're welcome.
So generally speaking, sometimes, and we'll get to this coming down to the end, there are different types of drops, serum drops, right? So there are different types and different classification of drops. So what you actually find happening is that sometimes your body adapts to a drop and the pressure is not going down or it's not staying within the normal limits. So your doctor tends to have to either change your drop or with your current drop, add another drop to the mix and see if it comes down, right? But we would chat about that later on as well, because sometimes you may have to use drops in conjunction with another type of treatment. Yeah. I think 6 to 7 hours sleep is actually marvelous, to be honest, though. But I tend to say try to get as much rest as you can and, have a chat with your doctor and maybe it's the type of drops, right? But don't go back and tell your doctor, the optometrist, say you have me on the wrong drops, please. Okay? You good, Jennifer? Can I proceed?
Yes, yes.
All right. So I'd like to move on to pigmentary glaucoma or pigmentary dispersion glaucoma. This type occurs when pigment granules from the iris build up in the drainage channels, slowing or blocking the fluid exiting the eye and raising the intraocular pressure. Right? So this is a case where it's just pigment from your iris could just cause a little blockage. Let's see. Let's go on to congenital glaucoma, and this is the rare form of glaucoma that is present at birth, resulting from an abnormal development of the drainage system. So in this case, you're required to resort to surgical intervention to correct, and could also be called normal tension glaucoma. So we'd like to go on to ocular hypertension. So ever so often, you might hear a friend or relative, or in my case, a patient say, they say I have high pressures, but I'm not on any drops. Why? That doctor must be a quack. Not necessarily. That is probably because you have ocular hypertension. So ocular hypertension refers to a condition in which the intraocular pressure is higher than normal. This condition is significant because it can increase the risk of developing glaucoma. However, not everyone with ocular hypertension could develop glaucoma, right? So in ocular hypertension, the intraocular pressure is higher than 21. However, in persons over the age of 70, ocular hypertension presents when their intraocular pressure is higher than 24. All right? The risk factors. The risk increases with increased intraocular pressure.
Oh,
Age.
Candice, 1 second,
Yes.
sorry. We have a question from Patricia. Patricia, go ahead.
Yes, thank you. I'm so
Patricia, welcome.
You're most welcome and a very good presentation. I'm glad that you brought up ocular hypertension because actually the treatment for ocular hypertension is the same as for glaucoma. So when does the doctor diagnose glaucoma after having ocular hypertension for some time?
So that's a good question. So according to textbooks or literature, they would say to you, most practitioners should treat every patient with intraocular pressure higher than 30, right? Or more. And if your intraocular pressure is higher than 21, in some cases, they monitor you. However, remember, it's a case-by-case basis, and they don't just take the high intraocular pressure, they tend to have to monitor the optic nerve to see if there is a change. So in some cases, they might see you every 6 months, or they might see you every 3 months just to monitor you, and then they will decide. So it's really a case by case basis. They would do the visual field, OCT, and so forth, right? And monitor the angles. And so it's you can't specifically say at this point we're going to start this person on drops. It tends to be generally case by case where they monitor you closely. So what I say to patients, don't miss the appointments, because people get tired and they're like, well, I'm going to these appointments and they just telling me, come back, come back. I'm not on any drops. I am not going back. No, you still need to keep those appointments.
So could you talk to the peripheral field of vision? Because that is important, particularly when people have to drive, when it comes to diagnosing glaucoma.
Correct. So when we refer to the peripheral vision, yes, that's important in driving. So we tend to look at the visual field loss. So what happens, and I don't think I mentioned this, so what happens when glaucoma advances and it causes the visual field loss? You have tunneling in of the vision. So it starts to affect the periphery first, and then your central vision gets smaller, smaller, smaller until it becomes dim. So the ophthalmologist would actually tell you, okay, when you should stop driving, because they would do a visual field test, right? Or you might come in to see the optometrist, and if you do a visual field test there, we might tell you, you may need to have a chart, but now is the time to slow down. So we tend to look at the visual field results, and that gives us a better insight as to when someone should stop driving. And to be honest, some patients know, but sometimes it's denial, but also remember, some patients are so independent, it's hard for them to ask someone to take them around. So, it's one of those things. So the visual field test would have, to be specific, the visual field test would give us some guidance as if there's peripheral vision loss, how much, and then if it's quite a considerable amount of field loss, we recommend that, you cease driving.
Candice, last one for me on ocular hypertension in terms of connections for persons who either smoke or vape. Does that impact the quality of life as it relates to keeping the hypertension at the rate you said, the range rather?
Well, funnily enough, I read a couple articles today in preparation, and what you found is like vaping and smoking would also increase the risk of glaucoma, as it does to anything else. So I would say try to cease. I mean, it's one of those things, if you're accustomed smoking 10 cigarettes a day, it's difficult to just go down to 0, but everything in increments. So, you just try bit by bit to reduce your intake of the nicotine. And also remember, although the vapes may not necessarily have the same as the cigarettes, but it could also have other chemicals that could be harmful. So that's why they advise not to.
So thanks again. I mean, I don't want to take up too much time, but please go ahead.
Right. So another risk factor of ocular hypertension, we look at the cup-disc ratio, which is the CD ratio. So the greater the CD ratio increases the risk, and may be because of an optic nerve head, which a larger cup is more vulnerable. And another risk factor would be the pattern standard deviation. And this is more specific for when we do the visual field test. So if there's a greater or high pattern standard deviation results, the risk increases significantly of developing glaucoma. So we're going on to the interesting stuff. So glaucoma treatment and management. There are different modes of treatment. And we have conventional eye drops, and there are different types of conventional eye drops. There are the beta blockers, the alpha-2 antagonists, prostaglandins, topical carbonic anhydrase inhibitors, and miotics, right? So if you want more information of this, I'm going to challenge a pharmacist or retired pharmacist in the group to volunteer to do a webinar on the different types of glaucoma drops and how they operate. Okay? I know there's a pharmacist or retired pharmacist here. Maybe there's probably more than one. All right?
That sounds great. The need for
Yeah.
information sharing, certainly.
Yes. And if you want, I will give you a name afterwards. So let's go on to laser therapy. So there are different types of laser therapy. There's argon laser trabeculoplasty, and then there's the selective laser trabeculoplasty. This is called the SLT. So I've known patients who were on drops for years, and the drops haven't been working, or it just no longer worked. And in this case, they have had to do the SLT. So in some cases, when you do SLT, you no longer have to be on drops. And in some cases, when you do the SLT, you may still have to use drops. So don't just go feeling, okay, if I do this form of laser therapy, I will no longer have to use drops. It's a case-by-case basis, right? So each case is unique, and it depends on the ophthalmologist, his findings, his care, that kind of thing. But one of the reasons the SLT is actually being promoted is because patients don't like to use their drops. It's just reality, you know, we get fed up, we're human, right? Another method of treatment is the trabeculectomy. And then you have MIGS, which is the minimally invasive glaucoma surgery. Couple pointers. Each patient is unique. It is necessary to consult with an ophthalmologist to determine the most appropriate treatment for you. So preventative measures, and we're going to take our time with this, right? And I'm sure you could share this. I'm sorry about this little marking on the screen. I'm not even sure how to get it out. But I would make this one available at a later date. But I really want for you all to share this information, all right? Regular eye exams. Comprehensive eye exams can detect glaucoma early. Generally speaking, adults should have a baseline eye screening at the age of 40. Remember, I said glaucoma is quite aggressive in the Caribbean. And it's only since I've been back home is where I would see someone who's age 18 with glaucoma, age 20-something with glaucoma. So even if you're not 40, just don't think, well, I'm not 40 yet. No, still just have a routine check. That's how, you know, you could actually save your sight, right? Know your family history. You know, we have some young folks out there who, when you ask what you have or what that drop is for, they say none of your business. But still, I would suggest asking. And the reason for that is you would like to know your family history. So you know, okay, I have a family history of glaucoma. I should probably test my eyes yearly. You know, or I don't have a family history of glaucoma. I'll just stick to a standard 2-year eye test. Okay? Exercise. They say regular exercise reduces the eye pressure. This is what some studies suggest. And protective eyewear. Wear protective eyewear to avoid eye injuries. You know, some of you are like to use a walker without wearing your safety shields and so forth, right? The aim is to protect the eyes for as much as possible. And let's go on to healthy lifestyle. Maintaining a healthy lifestyle overall, a healthy diet, and avoid smoking, okay, to improve your eye health. Medications. Follow your doctor's instructions for prescribing eye drops and medications. Yes, the drops are expensive. I know. Yes, it could become tiring. Yes, you're trying to stretch it out for as long as you can. Yeah, but just think about, should I use the drops or could I live with losing my sight? It's, you know, a toss-up. You decide. By understanding the nature of glaucoma, recognizing the risk factors, and taking proactive measures, individuals can better protect their vision and maintain eye health throughout their lives. Any questions and/or concerns at this point?
We have one question and then we have a hand up. So I'll just take the question first. Does exercise really reduce eye pressure? I exercise more. And I would say, Jennifer, yoga is also something. But let me hear you, Candice, followed by Maria had her hand up as well.
I have
So,
the same question. It's the same question.
Oh,
so, funnily enough, I read this and this is what the textbooks say, but I can't tell you definitively. I would probably have to do some more research so I could get back to you as to whether exercise just generally, reduces the eye pressure. All right.
On that same question, I was wondering, is it eye exercise or whole body exercise?
I believe they're referring to regular exercise.
Oh, okay. Because I know
Yeah.
about eye exercises as well, eh?
For glaucoma?
Just in general, there are eye
Yes.
exercises.
Yes, in general, there are exercises, but they're for different things, different aspects. One reason sometimes we recommend eye exercises would be for patients with extraocular muscle palsy. That's one reason why we'd recommend eye exercises. A lot of children, sometimes we have to recommend eye exercises, but that's a whole different topic.
Hi, I don't know if I have glaucoma, but I'm a seamstress. And sometimes, like right now, if I take the glasses off, I'm seeing blurry to the point where I cannot see properly. And I do have to like walk away and look at outside the greenery and stuff outside for like maybe 5, 10, 20 minutes, maybe, and then go back. And I have something they say is a stigma, so I don't know.
Right. So it would be hard for me based on what you just described. I have an idea, but without knowing your entire ocular history, it's hard for me to really give a definitive response. But based on what you described, when you wear your glasses for sewing, for near task, when you remove it, the eyes give problems readjusting. So that's why your vision is blurry. So you have to take some time, go outside, look in the distance. So that's normal. It just probably means you may need an eye test. I don't know what strength of glasses you're at, how long ago you had in glasses, and what
I'm
your
going to be
vision.
very honest with you, is I'm actually wearing a glasses from Superfarm.
Oh,
Yeah, I'm not gonna lie.
yes.
And as you said, something about nearsighted and farsighted. I can see farsight, but I'm nearsighted to the point where, like, when you put your hand like here, I cannot see properly. I have to like
Okay.
cross the
Hold it
eyes.
further away.
Yeah, cross the eyes, like cross the eye to kind of settle, and then maybe, and with a little blue.
What's your age, if you don't mind me asking?
51.
How old?
51.
Right. So you are due for an eye test, right? Because if you're using the glasses from Super Farm, no disrespect to those glasses, there are cases where I may recommend it, and that's just like in the minority on the odd occasion, not very often at all. You are due for a comprehensive eye test because what's happening is you may actually have two different prescriptions between both eyes. Those glasses don't take that into account.
Right. And as I said, I only use it for like when I'm on screen time. And so other than that, cannot use it at all.
Correct. So this is where you need an eye test, and I can't recommend anything without knowing your visual acuities. But what I would suggest is you go to your optometrist and you get a comprehensive eye test done. They would check your visions, your visual acuities, and they would tell you what prescription you have. If you would have been told ages ago that you have an astigmatism, again, the glasses from Superfarm does not take that into consideration.
Okay.
Yeah.
All right. Thank you.
You're welcome, my dear.
I have another question, Candice.
Okay.
What is the usual length of time you recommend to change glasses?
That varies from person to person. And for it it's I wouldn't say it's a gray area. Each person is unique. So let's say it depends on a child. So a child would have to test their eyes every year or every 6 months. You might find they have to change glasses every year or every 6 months, but then they might have a year where they don't need to change because there's no prescription change, right? So generally speaking, it varies from person to person based on if there's a prescription change and also the condition of your glasses as well. Right? So let's say you have a family history of glaucoma, we would recommend that you should have a yearly eye test, but it doesn't mean that every year you have to get new glasses. It's just to make sure everything's still functioning, everything's normal, there's no sudden changes, things like that.
Patricia has her hand up. Go ahead, Patricia.
Yes, correct, Candice. But I know that many of the health plans are now allowing you to test your eyes every year, whereas long ago it used to be every 2 years. You can
So
hear me?
yes. So you're asking about the health plans.
So I'm just adding that information.
Yes, correct. So some health plans are allowing you to test every year. It just depends on your provider and the type of policy you have. Some would say every 2 years. Some are allowing every year, but you can't purchase glasses every year as well. So they might say, okay, you could purchase frame and lenses every 2 years, but lenses alone every year. So it just depends on your provider. Thank you for that part.
We have no other questions, but again, being mindful of the time. So go ahead, Candice.
So we're on to so like I said, each patient is unique. So each patient has a unique medical need, and there's never a clear-cut method of management. The aim of today's webinar was to provide a general overview of the medical care principles. It is important to respect the expertise of the medical practitioners and to not self-diagnose or tell your healthcare provider how to do their jobs. Always seek professional advice for all your health concerns before consulting with the internet, i.e. Dr. Google. Okay? So I was happy to share this information with you all. I hope it provided a little bit of insight, and I always encourage an open and honest discussion with your healthcare provider, whether it's your optometrist, your ophthalmologist, probably even you probably never had an eye test before, but you have a general practitioner who you tend to see on a regular. Have the discussion with them. All right. Any other questions?
So far, there are no questions in the chat. Again, at this time, guys, you could unmute. Patricia, go ahead. It's yours.
Just have a comment. Candice, when you're talking about diabetes and how diabetes is diagnosed, I think you can add in hemoglobin A1C because many doctors are diagnosing based on the hemoglobin A1C figure. And now they're talking about pre-diabetes and stuff like that. So just to add, just a comment. Very nice presentation.
Thank you for that, Patricia. So the HbA1c, yes, the hemoglobin A1C is what most doctors are using. They're saying it's more accurate than even the at-home test. That is correct. And also, what's the other thing she said? And also pre-diabetes tends to be between 100 and I think, so once you get to 101, they're considering a blood sugar level of 101, they consider you to be pre-diabetic now, unfortunately. So I guess, everyone should just invest in a kit and you don't have to go all crazy and check your blood sugar level every day or 3 times a day, but just, I say at least 3 to 4 times a week, first thing in the morning before breakfast. Just, because knowledge is power.
We have some other hands up. go ahead. Well, Maria and Maria, whichever one comes first.
Yeah, Maria.
Hi, Maria.
I want to find out, is there any public sector optic care? All these that
Yeah.
you're offering, because you are talking private care. Is this available in the public sector?
So in terms of, I will start with ophthalmology. There are private ophthalmologists, but there are also ophthalmologists who works in the hospital system. So Arima, Sandy Grande, Mount Hope, Port of Spain, but I think the Port of Spain Eye Clinic is now in St. James, so they call it the St. James Eye Clinic. San Fernando General Hospital also has an eye clinic, right? So they have ophthalmology days, and there's always an ophthalmologist on call in case of emergencies. They will call someone out. But there are specific days, and they may have more than one consultant ophthalmologist, and they would operate on different days. So, like, I know there was someone specific for Mondays at the Mount Hope Eye Clinic, right? I don't know if that's changed. I think they may have someone else. But yes, each hospital has an ophthalmology unit. So if it is, let's say, an optometrist gives you a referral letter to go to an ophthalmologist, you take it to the hospital. It's just that it takes a little while before they call you, right? And it's just an unfortunate situation where it could take a while before they call you, but you do get called. And if you don't get called, I say, photocopy that letter, make sure and keep a copy and go again. All right, for those who cannot afford the private healthcare. In terms of optometrists, I know some of the hospitals would have or probably are hiring optometrists to test children. So there is a pediatric clinic in Sandy Grande Hospital, I believe. So that's for, let's say you have an impoverished child. Is this Maria, who's a teacher?
Yes, because
Right.
I have
So-
another question coming out
So
of
if
that.
you have an impoverished child who cannot afford to go privately, they could actually test in the public sector. They may have to go out to get glasses in the private sector. I think there was some sort of visual screening arrangement with the schools and the ministry. However, I'm not sure how reliable it is, or which companies has that contract to supply specs. I could find out.
I also want to find out, now I remember I was dealing with a child who had glaucoma. And I found that we, the teacher, because we actually went through where she was getting blind, and then eventually we didn't see her. I found that we should have had some sort of a personnel to help us deal with her. And I was wondering too if like with children especially going through this thing, is there a therapist who will go through them? Because I think this is a shocker to know that you would have been able to see as a child and then you're going through this.
So that might be something to contact the Ministry of Social Development. There's also the Blind Welfare Association, right? And there is also, I believe it is Harvey, right? I could double check these places and see what facilities they have in place for persons who are blind, especially children. So I have space for 2 more questions. Maria, I hope that helps. If you have any other questions though, I would suggest you could, I think, send it to Susanna and she would send it to me and we'll be in touch. Any other
I
questions?
thank you for your information, and I look forward to, because I do want to get that info that you gave, those places. I think that is something that we would need.
Okay, no problem.
Thank
I'll be happy to find out for you.
Okay, great. Thank you.
You're welcome, my dear.
So we have one from Rhonda and one from Jennifer.
Hi, Rhonda.
Okay. Greetings, good evening.
Good evening.
Ifabumi Rhonda Valentine Charles here. Okay, Maria raised a concern with support, and Candice, you were correct with PAVI. PAVI does provide support for people, right, who may have the shock of being blind or going blind. PAVI does assist with that. Concerning Maria, a lot of people don't seem to be aware. I worked in the health ministry for almost 38 years. Although it was in the clerical field, I can tell you what happens. So you go to your GP or you may go to the health center and you have a problem with your eyes that they would notice. They will give you a referral letter to take to the hospital eye clinic, right? So you go to the eye clinic and you carry a letter. Yes, Candice, it does take long, people. Patience is the key, but this service is free of charge and has been offered to the citizens of the Republic of Trinidad and Tobago. Well, I was in the health service for 38 years. I am now 74. So ever since I know, right? In all, I could speak specifically about the Port of Spain General Hospital Eye Clinic. They do have ophthalmologists in session every day. So I am a patient at the clinic, right? I am suspect glaucoma and cataract, hereditary from my father. I go to the clinic, and on the days when I go, there are always ophthalmologists in attendance, and they do see you, not optometrists to the best of my knowledge, right? I don't know about the treatment for children as you were suggesting, Candice. I don't know. I know about the adults, right? So we do have ophthalmologists in the public healthcare system, and they are always there. So when you go on your clinic day, you are seen by the ophthalmologist. You do get medication in the dispensary. Port of Spain General Hospital, the eye clinic, they have their dispensary on spot, right? Because I get my 2 sets of drops right there. No problem with me. People who don't get, well, they buy outside, right? But most people seem to get what is prescribed for them at the Port of Spain General Hospital Eye Clinic dispensary. And I would suppose that once the new central block of the Port of Spain General Hospital is completed, I don't know what this current administration would do. The eye clinic will be moving back to the compound of Port of Spain General Hospital. Okay? A ton of information.
Thank you for that, Rhonda.
You're welcome, darling.
Right. So I'm not seeing any other questions at this time. It's now, again, 8:12. So I would like to take this opportunity again, thanking Candice for taking the time. Well, we have Mr. John.
Yes, correct. Just to add, the same service is also at the Arima Hospital. I attend there, right, as often as I'm told, and the dispensary is right next door, and you are seen by the ophthalmologist. Okay, and it's also available at the San Quentin Hospital.
Thank you very much, John.
Very good. I think too, by extension, guys, this information sharing, it will give comfort to all the areas of eye care professionals that if they could extend that information more readily, people are able to know there's avenues at the point of when it's detected, that early detection, which is what we are hoping that this presentation could be a benefit to you and your loved ones. So together we are going to try and make a difference by sharing information from practitioners in the field, as well as, other persons in this space. It's all about giving of ourselves and information. So until next time, we would like to wish everyone a great night and take care. And please keep an eye on your vision. Over to you, Candice.
Thank you.
Thank you very much, Susanna. I couldn't have said it better. Thank you very much for attending. And I always say to my patients, your eye don't grow back like your fingernails. We need to cherish it. We need to take care of it. And I have seen over the years so many people go blind simply because I would have seen so many people go blind simply because of the mere fact that they didn't listen to their optometrist. They didn't do the visual field test. They did not, hold on a second, sorry about that. They didn't do their visual field test. They didn't take the drops. They stopped using the drops. All right. So remember, knowledge is power.
So thanks again, everyone. This takes us to the end, and we wish everyone a restful evening and the rest of your week. Be safe. Bye, everyone.
Bye,
Bye.
everyone.
Thank
Thank
you.
you very much. Bye.
Very much.
Thank you.